I thought before I read Corey's bio, because it's shifted recently and it's very detailed, he checks a ton of boxes, I wanted to share a quick story about how Corey came to be on this stage. Some of you know that I worked for the Department of Human Services for a number of years, kind of as a generalist there over the Government Affairs Committee. And about 3 years ago, I left the department and started in the substance use disorder field. And to ramp up, I started watching some YouTube videos and what have you that were online. And I bumped into this guy named Corey Waller. And I was like, this guy is the bomb, you know? And so sure enough, I started going to conferences and what have you. And now I'm bumping into Corey speaking at conferences and got an opportunity to meet with him and talk with him after. And then shortly thereafter, I was connected with him through HMA. And henceforth, he's here today speaking before us. He plays an important role in addiction medicine. And so I am thrilled that he's here. We are embarking next year on a revision to the ASAM Criteria, which Dr. Waller here is working diligently on. And so want to thank him for that. And hopefully everyone here has got their pen poised to take notes, because we got a lot of ground to cover. So with that, I'm going to read a bit of Dr. Waller's bio and then turn it over to him, and we'll go from there. So Dr. Corey Waller, and I will say he has most of the alphabet letters behind his name. So I won't read all of them at this moment, but he's board certified and actively practicing addiction emergency medicine as a specialist with extensive experience working at local, state, and national levels. He works with the American Society of Addiction Medicine and related organizations to advance evidence-based practice of treatment and recovery for individuals affected by addiction. A nationally recognized expert in SUD, he's now the chief editor of the ASAM Criteria. As the chief medical officer for Brightview Health, he is responsible for quality of care, education, and service characteristics for over 400 providers in 90-plus locations across 7 states. Brightview delivers a full spectrum of outpatient addiction treatment services, including COE and the treatment of special populations. In his prior role as managing director of the HMA Institute on Addiction, he was directly responsible for consultation regarding addiction treatment systems, development for hospitals, primary care practices, justice-involved populations, and addiction treatment providers. He oversees the HMAEDU.com learning management system and develops education covering addiction, pain, behavioral health, and administrative support for those systems. Before HMA, he was the Senior Medical Director for Education and Policy at the National Center for Complex Health and Social Needs. Dr. Waller was responsible for developing and maintaining all training and in-person technical assistance delivered by the National Center. Prior to joining the National Center, he worked for Spectrum Health Systems in Grand Rapids, Michigan, and fully integrated health systems with 14 hospitals and over 1,000 employed physicians. Dr. Waller served as a medical staff chief of pain medicine to the Spectrum Health Hospital System and a medical director of the Spectrum Health Medical Group Center for Integrative Medicine. Dr. Waller received his master's in biology degree in neuromolecular focus at Southwest Texas State University, and his medical degree at University of Texas Health Center in San Antonio. He completed his emergency medicine residency at Thomas Jefferson University in Philadelphia and is board certified in emergency medicine and addiction medicine. So with that, I would like to ask you to give a warm welcome to Dr. Waller, and looking forward to the information he has to share today. Please welcome.
Thank you. All right. So I'm sure other speakers have talked a lot about how it's nice to be back from COVID because we get to actually be in person and these pieces. I found out that this is like my third time to give a talk kind of in person post-COVID, and I realized how out of practice I was because I woke up this morning and flew in from Detroit, but when I was getting dressed, I realized I left the pants of my suit at a hotel. And so therefore, this is what you get. This is what was left over from the COVID closet. And so there we go. But I think my hope is that by the end of this, you will be full. And I see by the fact that it's Mexican food, I'm glad I'm talking during lunch rather than after lunch, because the Mexican food coma, being from Texas, is a normal reality. And so we'll try to get some of this into your brains before the belly takes over. So I was asked to talk about, what is the fourth edition of the criteria that's coming up? And I think it's important to understand kind of where I come from this role. So I have no disclosures, and what that means to me is that I've never taken any money from pharma. I don't take any money from device. Even now, I'm a chief medical officer for a Medicaid provider. It's a for-profit provider, which was the evil empire for me for a long time, and so I had to sign on as a non-equity partner, which means I get nothing if they make a product. I'm not connected to that side, because it's really important that as we do this work and we start to look at it, that we use the data, science, and math to make the decisions for what the system should look like. Now, I've worked in many places in the system. I've worked as I was a paramedic before I went into medical school, and then at that point went emergency medicine in Philadelphia. I've worked in outpatient, I've worked in inpatient, I've worked in ICU, I've done, I've worked in the operating room when I did interventional pain, and then I did street medicine for 2 years in Camden, New Jersey. And I think I learned more from that 2 years about addiction and the realities of it than just about any other place that I've worked. So as we walk through here, we have to recognize that addiction is a team sport. A doctor doesn't walk in and magically make something better. A therapist doesn't walk in by themselves and make everything better. It is a combination of players, and it is the doctor, the therapist, the counselor, the peer, the system around that, the community with which that person sits. And if any one of those are a weak link, then people will have a higher risk of relapse. And a higher risk of relapse in this world right now means a risk of instantaneous death. And instantaneous death is, I'm going to use once today, it's got fentanyl in it, now I'm dead. And so how many people here have reversed somebody with naloxone? Right, so how many people carry naloxone with them? Right, I got like 3 doses in here because I got in my backpack because I got spooked when I was doing street medicine in Camden because I ran out of Narcan in my medical backpack, emptied out the truck one day when EMS pulled up because carfentanil and sufentanil was on the streets at that time, and we ended up giving almost 20 milligrams of Narcan to one patient just to wake him up, and all they had in their system was opioids. So at the end, that one overdose risk, that one time, that one day, that one person they were with could be the end of that day. And so we have to build a system with resilience and that appropriately overlaps. So my hope is that by the end of this, we can really understand all of the components required for addiction care to work, because it's not just I write a script and you're golden. That's not the case. I want you to make sure that you understand what's coming, because the fourth edition is a pretty big change from the third edition in a number of ways, and we're going to talk about that. It's not so different that you're not going to recognize it because it's written into the laws of 24 states, so you can't just blow it up and start over. You have to kind of mash at it and move it around as best we can. And then I want to make sure that you understand how to approach the care to the people you see tomorrow, or the people you take a call from your clinic that you're not at right now later today, and you know something better or different that you can do. So those are the goals. So if we look at the components of care, we talk about, well, we have addiction treatment. And I want to make sure that everybody recognizes that what we do requires a Venn diagram of work. And so we have medical care, we have psychoeducation, we have psychotherapy, and psychotherapy is very different from psychoeducation. There's some overlap, but you cannot replace one for the other. They have specific things that they do. And then you have the therapeutic milieu, or the recovery services that we attach to that. What supportive aspects? Does somebody know how to go get an ID? Can they get a job? Do they know how to interact with a person and make a friendship? Because they haven't been able to do that for years. Because as we know at its core, addiction is a disease of isolation. And so the more isolated that somebody becomes, the longer period of time that they do that, the harder it is for them to get back out and actually interact with other people and interact with them in such a way that they can actually, be productive in the way that they want. So if we look at these a little more deeply, and we look at the medical care, this is the care that's generally going to be delivered by a doctor, a nurse practitioner, a PA, an APRN, RN, LPN, MA. So everybody who has any medical thing, from taking a vital sign all the way to doing surgery on somebody with a heart valve problem, is kind of the entirety of this group. Now, that should include a lot of different things. So it's not just medication. If somebody comes to a clinic and has an opioid use disorder, or an alcohol use disorder, or a tobacco use disorder, we have a few things that we can do. Some of those are medication related, but that's just the beginning. What about, do they have hepatitis C? Do they have HIV? Do they have other sexually transmitted infections? Do they have options of birth control available to them? Because I will tell you, when somebody shows up to the clinic that treats their addiction, they don't want to go anywhere else. They don't want to have to also go to another primary care doctor who's going to talk to them weird, or make them sit out front, or talk smack at them, or get I grew up in Texas, so the mal de ojo, that they're going to give somebody from the front desk of you not wanting to be in that office. They want to get the care where they want to get the care, and typically that's the place where they feel most connected to. So medical care for this population is more than just writing buprenorphine or giving a dose of methadone. It is the totality of not only identifying these diseases, but it's the treatment of those diseases. So if somebody shows up to one of my clinics in my new role, we would test for hepatitis C and HIV. If they have hepatitis C and they meet the criteria, we would start treatment in-house. If they have a sexually transmitted infection, we would then identify which one it is, then we would treat those things. And then we would monitor it over time, and then do teaching specifically for the behaviors associated with how that was obtained. So that's the totality of medical care. It's not just, did I hire a mercenary doc who comes in for a 1099, 2 hours a week to bless something and write a couple of scripts and high-five you and leave. That's not medical care and addiction. So what about the next group here, when we start to look at things like psychoeducation? So I would say psychoeducation is the clear majority of what occurs in addiction treatment at this point. So if I wanted to teach somebody algebra, do you think you need to be in a pretty calm, stable frame of mind to onboard new learning about algebra? Do you think you need to not be in withdrawal? Do you think you need to, can you imagine trying to learn, logarithmic scales while you're in withdrawal from opioids or alcohol? Or have you seen the person who's been on methamphetamine for 2 years now off of it, where you can't even shake awake? You're going to teach them algebra? It's not going to happen. Well, the reality happens is that people start in on psychoeducation at this stage of the game, and nobody can onboard that. If somebody has a significant mental health disorder, with that mental health disorder, they're not going to be able to really take on new education until we can help them stabilize that disordered thought. So they may require psychotherapy prior to psychoeducation. So psychoeducation is a lot of, anger management. So like the TCU anger management manual, where you walk it down, it's already written, you deliver it as written. When you look at seeking safety, so something like that, where you have a group-based approach where it's very manualized, we know exactly what it is, and you deliver it. The person delivering that, their job is not diagnosing and pivoting treatment based on a diagnosis. So typically this is going to be delivered by counselors, by peers, and can be delivered by everybody else, but the wheelhouse is going to be for those people who are bachelor's level, associate's degree level, that don't have a legal capability to create a diagnosis, but can definitely deliver stabilizing intervention and that. But if it's not delivered at the right time and in the right place, it's useless. So think about if your job is delivering psychoeducation every day, and 80% of the people you deliver it to, it does nothing. Does that feel good? No, that sucks. That's terrible. So what we want to do is figure out how we put it together along with things like psychotherapy. And so if we look at psychotherapy, that is, talking about a licensed master's level social worker, and a licensed clinical social worker, master's psychologist or PhD psychologist. Psychotherapy is a different modality than just giving somebody didactic education or using a standard modality of treatment. It is the ability to diagnose someone in real time and pivot your therapeutic approach in that time frame. So you have to, one, have the license capability to diagnose, and two, you need to know how to pivot. You need to know how to pivot from CBT to the subset of dialectical behavioral therapy. And to be able to do that so that you know that this person has a personality disorder, so now we need to move into the dialectical behavioral therapeutic aspect and pivot that treatment so that they can go down that pathway. Or realize that the clear majority of their issue is actually not psychiatric by itself, but just trauma. When I say just trauma, single incident trauma needs a heavy lift from like EMDR to start with, so you need somebody to pivot and deliver that treatment. So these are very different pieces. And when we move over to this piece right here, when we talk about the addiction treatment milieu, recovery supports, these are the things that I think as a field we have completely failed at explaining to payers. So how many times does somebody say, well, they need to go to recovery housing, and they meet for like a NAR level 2, and they need to go to recovery housing, and somebody's like, well, I'm not going to pay for that, that's just housing. Well, it's not just housing. It's a very different thing than just housing, because we're actually teaching somebody to do their laundry, to take inventory of their stuff, and to understand how to interact with other people, having a positive peer response for people around you when you have some craving and somebody else helps you through that moment. When somebody has to open a bank account, to go get all of these other things done, that is a required element to people who have had destabilized long-term addiction. And so in that setting, what we have to be able to do is add the support, the structure, and the consistency and cohesion so that people can feel vulnerable safely and then open up to the things that they want to get better. So if you pick any one of these, that's not enough. It's not going to do the trick. If you have an alcohol use disorder and all you deliver is psychoeducation, you're only going to be successful about 12 to 15% of the time. So what does that mean? 85 to 88% of the time you're failing. So that means 88% of the time we're paying for something that we're getting nothing for. And so we have to realize that connecting all of these pieces together is what's important, and applying it to the right person at the right time. Because there are people that the stage of recovery they're in, this is what they need. And there are people that we have to be able to overlap into those other pieces. So we know that it looks like this, but how many people in here work in a clinic that have access to all 4 of these quadrants? Mostly not, right? Well, this is a part of the way in which the system has been built and paid for. So if we look at the way that the system has been built and paid for, we pay for medical out of a completely different bucket than we do psychotherapy. Psychoeducation, generally speaking, isn't paid for unless it's paid for through a day rate and paid for, in a, here's a bundled rate for this period of time for this thing, but not really on a per session approach. And then we have the treatment milieu, which generally we're just expected to do it for free. So this is where the next edition of the criteria tries to pull this in. So how many people are familiar with the ASAM criteria? Right? Anybody over here? I know you guys started later. Anybody familiar with the ASAM criteria? Ever heard of that? Well, it's about to be what pays for your entire system of care, so you might want to listen. And it's most likely going to comport with this. So if you get a paycheck that is about addiction treatment, this will be driving your paycheck coming up. And if you don't follow this, I'm pretty sure your paycheck will dry up pretty fast, because that's what's happened in the other states that have applied this. So as we move here, we wanted to move away from just a book written by a few people who think they know parenterally what's better for everybody. And so we stepped back and we created a methodological approach to this. So what does that mean? So that means we created 17 separate writing groups. We did deep dive analytical evaluations of the literature. We then decoded all of that literature. came up with what that meant for those levels of care or that type of approach and who should be staffing and for how long and how we figure out who should go where. And then we wrote that section, and then we sent it out for a third-party evaluation for voting. And then it came back for a reevaluation. This is called a modified Delphi, and this is what we use for building guidelines. So once we did this, we realized that addiction treatment had become so disaggregated that people weren't getting what they needed. So you have somebody that says, I'm an IOP, and that's all I do. I do detox, and that's all I do. I do just an outpatient treatment, and that's all I do. And as we talked about earlier, that doesn't work. So what we wanted to do is aggregate withdrawal management back into the levels of care, instead of there being levels of care, withdrawal levels of care, adding on COC, adding on bio, and all of these other things that nobody understood and nobody was doing well anyway. Combine all of those back into a single system of care that makes sense. So we did that. But in order to do that, we had to deepen and then modify the dimensional analysis, the 6 dimensions that we use to identify person's integrated need for care. We then wanted to simplify the withdrawal management so that we weren't trying to figure out, you know, well, there's no quote detox unit in my state, what do I do? Or there's nothing in my region. And so we did what the literature said, which is said a lot of this can be handled in the outpatient space. We want to further define outpatient care. Separate and enhance justice involved in adolescence. So in the adult criteria that comes out in the 4th edition, there will not be adolescent. It is too different from the standard criteria, and so it has been separated from the criteria, and we are building an individual criteria for adolescents, which is going to push care toward home-based care, school-based care, community-based care, rather than residential treatment for adolescents, because the data is very clear that if you yank an adolescent out of school and away from their friends and away from their location and you shove them in detox, they are fully disconnected forever. We don't just pull them out for treatment and say plant them back in. It doesn't work well at all, and relapse is almost 100% at 1 year in that group. So we're changing those levels. We're about to publish the ASAM criteria for jails and prisons, specifically for what should be done inside of a jail and inside of a prison. And those are very different than what looks like on the outside. You're not going to have all the levels of care in a jail. You're going to be like, do you want treatment or not? Let's be honest, that's what you're going to get. And you need to add medication, and for those that want treatment, have a standardized psychoeducational portfolio of services with medication and oversight, and get them ready for landing back in the community when they're done. And then for prisons, it's a little different because they have a longer period of time. And we want to make sure, most importantly, put all of this online and update it annually. So instead of actually just having the criteria out and then 10 years later redoing it, we'll have annual updates to the specifics so that we can all keep up with it and make sure that the data doesn't get so far ahead of what the guidelines say. The biggest change to the dimensions sits here. So if you look at the 6 dimensions, we would typically start with intoxication and withdrawal. We would then go to medical, and then we go to psychiatric or cognitive pieces, and then we would go to readiness to change. Well, the problem is that readiness to change by itself does not determine level of care. And so many people misinterpreted that, and we have states that would say, well, if they're not ready to, they don't have any readiness to change, I'm not going to say yes to them getting care at the level of care that they need, because they're just not ready. And you know, we've all heard if they're not ready, they're not going to engage. And my answer to that is that, well, that you suck at, motivational interviewing. Because that's the whole point of doing motivational interviewing and interacting, is to take somebody who is pre-contemplative and move them through those stages of change to the point where they're like, all right, I can try this today. That's our job, right? And if you're not able to do that, then you might not be very good at your job, and you should think about that and maybe get better training. And then we would go to relapse and go down to living environment. But what we realized is that this was out of order and was hard to treatment plan around this, so we wanted to make it to where when you do an ASAM evaluation, not only do you have a level of care, but you've now developed your treatment plan. And so in order to do that, we start with the same first, because intoxication and withdrawal can put you in a hospital, right? Medical problems can put you in a hospital. Psychiatric problems like psychosis and suicidality can put you in a hospital. But substance use related risks or risk of relapse, that won't put you in a hospital, but you may need residential treatment. And then when we look at recovery environment, That's not just do you have a house, that's even if you have a house, are you able to go there and actually interact with your family to the point where you're not going to throat punch, the person sitting next to you? These are important components that we look at. And then once we determine level of care, then we can look at readiness and resources, which is the social determinants of health. Because some people may be perfect for a 3.5, but they're like, I got to take care of my mom. I can't go to residential treatment. I have a kid, I have a dog, I have a whatever, I have to keep my job. And so we can't just be like 90 days away. I mean, how many of us could just go for 90 days and we got everything covered? Bills, kids. No, it just doesn't, it's a little ridiculous. And so when we look at this, what we want to make sure and do is get people where they need to be for the time that they need to be there, but also give them some choice in the matter. And so that's what this readiness and resources looks like. So these are the new levels of care that'll come out in the 4th edition. Now, if you look here, they're aligned both vertically and horizontally. If you look over to the right, you have 4 at the top. That's a hospital. It's a little bit farther. But then you'll notice we have 0.7s. The 0.7s are where medical care takes place, whether that's residential, high-intensity outpatient, or just outpatient. The 0.5s are where therapy takes place. So 3.5, 2.5, and 1.5, that's where a therapist will work. The 0.1s are going to take place where mostly psychoeducation. Now we are increasing what a 3.1 needs to do. A 3.1 is going to now need to deliver the equivalent of IOP level treatment in a residential setting. And what that means is that you have to go from 5 to 9. Whack. But nobody wanted to pay for 3.1 care, and I don't necessarily blame them because weekends are off, but you're still paying for them to be there, and that didn't necessarily make sense, and we didn't document it well. And then 1 is a new level of care. 1.0 is a recovery level of care. So for those in long-term recovery, they still need to be monitored with people who know what to look for. And then we've added recovery residencies as a level of care as well, and we'll talk about that. All withdrawal management and bio takes place in the 0.7s. So if you are at a 0.7, then you're going to get your withdrawal management and bio there at the level that you needed. And then co-occurring enhanced can be added on to any of the residential and increased intensity outpatient levels. So 2.1 through 3.7, you can add COE, co-occurring enhanced, onto. We'll dig in a little bit there. So we talked about the vertical, the 0.7, the 0.5, and the 0.1, but what about the horizontal? How many people are administrators in an addiction treatment delivery clinic somewhere, right? So I want you to pay attention to this. If you build a 3.7 residential treatment facility, you by default are already staffed to deliver a 3.5 and a 3.1. If you build a 2.7, you're already staffed to deliver a 2.5 and a 2.1. If you're a 1.7, then you can be a 1.5. So the goal here is that if you build a 3.7, you can actually be every other level of care without having to hire another person. And that's the way that we built it, so that if you build a 2.7, you can be every level of care under 2.7 without having to hire another person. So that's how we were building it, so that not only can you staff it and not have to say, well, I got to now buy a blank, 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 or have this many of that, but if you staff it as stated in the criteria, then you would be able to actually have and own all of these levels of care parallel and underneath that. So let's talk about the 0.7s, because there were a lot of questions about what is a 3.1, 3.2, 3.3, 3.3 withdrawal management. Is there such a thing? I don't know. It was confusing because the point something didn't mean anything. If anybody in here delivers 3.3 care, that level is gone. And I can explain that if you care to understand it. 3.2 withdrawal management is removed and embedded into all levels of care. COC, co-occurring capable, is now embedded in every level of care. That's expected to happen at every level of care. It's not a separate thing. So let's walk through the 0.7s. Most of it is medical, most of that. Not all of it, but most of it. And then you have some psychotherapy, which is more diagnostic in a sense. Yeah.
See, Brent. Can't hear me, but, now you can hear me. Thank you. I was wondering if folks could kind of keep, I'm getting some complaints from folks that they can't hear what Corey's saying. And so what I would love is if you're able to and want to stay, please listen or keep quiet conversation. That would be super helpful so others can learn, because MARRCH actually brought forward the 1115 proposal where we're implementing ASAM in the state of Minnesota in 2017. And so this has been very important for the state of Minnesota to learn and understand what is coming next. And so the folks that are here that want to kind of listen to that, they need to be able to hear. So can I turn it back over to you, Carrie?
Sure.
Thank you very much.
I have kids, so I'm used to just talking and people not paying attention and doing whatever they're going to do. So, which, by the way, when she said YouTube, that's the only thing that my kid thinks is cool about me. He's like, Dad, you got some stuff on YouTube. How many likes do you have? Stuff on YouTube. How many likes do you have? That's it. Has nothing to do with the fact that he gets clothing and a house and, baseball stuff, and we love him and take care of him and all of those. It's like, sweet Dad, you got like 9,000 likes. I'm like, yes, not from you. Did you give me a like? No, of course not. So when we look at this is the general approach of what should happen in a 0.7. So if you've worked around medical care inside of addiction treatment, you realize that up front, especially for opioid use and alcohol use disorder, most people need a lot of medical in the front end. They need a lot of stabilization. There's a lot of symptom management, a lot of evaluation, management of infectious diseases that we talked about. But in my clinics and nationwide, we find that after about a month, we become very quickly not the most important person in this person's care. But we need to have access to somebody who that can be handed off to. So that would be handed off to the psychotherapist. And the psychotherapist is important, whether it's an LCSW, an LMSW, or a PsyD, or whatever it is, that person is going to make sure that we're not missing the co-occurring disorders, to make sure that we're putting them on the right trajectory for any cognitive issues or other things that we need to. And at the same time, using some of the psychoeducational staff to determine are we care coordinating appropriately, are we able to get them in the right place, and then still doing treatment milieu. But the majority of a 0.7 is about medical care. The nice piece is that if you're at a 2.7, that means that inside those same walls, you're also a 2.5, and you're also a 1.5, which means that if we go to the 0.5s, we can quickly still continue to do medical care as they need it, but we shift rapidly to a deeper aspect of psychotherapy. And that is, again, diagnosis with a pivot to treatment. We start to increase the amount of psychoeducation, the amount of information we can give a person, the amount of things that they can take with them, the amount of skills they can practice. And then we add more to the addiction treatment milieu. Now, some people aren't going to need this much psychotherapy early, and they can go straight to a 0.1, which would put them mostly at psychoeducation, learning about the disease of addiction, understanding about anger management, going through some of the group therapeutic modalities. And then the addiction treatment milieu piece of this starts to increase consistently. And the nice part about that is that people should be able to get ultimately what they need. So if you're at a 0.7, so the typical opioid patient will look like this. I need a bunch of medical, I need some medication, now I need somebody to help me figure out why I'm depressed and I'm anxious and I can't sleep at night and I got other stuff going on. All right, now how do I stabilize my desire to not use when I'm out on the streets anymore and somebody walks up to me or my dealer calls me on my phone that I forgot to destroy and pull out the piece or whatever that is, or I get a call from my, the baby daddy who freaking makes me nuts and sends me off the deep end, and what do? Well, that's what the system should be set up for, is a true continuum of care, which is we meet you where you're supposed to be, and you should be able to get that in the same square foot of land. Instead of at one clinic you got to do this, then you got to wait 3 weeks to get into another clinic, and you got to wait 3 weeks to get into another space. This allows for any clinic at any level of care to do a couple of things to now become multiple levels. And with that gives you the ability to see patients for a longer period of time and give them more services without having to massively expand the people sitting inside there that you're paying. Now, what about level 1.0? Well, this depends on what the person needs, right? So this is a person who's a year and a half out. They're doing relatively well. Maybe they've had a couple of lapses. Maybe they've, had some struggles in their life, but they're still doing okay. They haven't fully relapsed. They show back up. And when they show back up, we need to be able to ask them real questions. not just the primary care version of this, which is, hey, how you doing? Because hey, how you doing doesn't fix the problem. What we need to be able to do is say, do an inventory of their recovery capital, evaluate the ways in which they've started to gain skills that they need to apply over time, and see if there are other things that we need to dig into and maybe to improve their capabilities even further. But for those people who still struggle with dimensions 5 and 6, meaning those dimensions of recovery environment and really the SDOH, they may still need recovery residencies to help them out with that. And so this would be a person, we could have a person that meets for 2.7 with a recovery residency, because they don't need residential treatment. What's the difference? What's the main difference between a recovery residency and residential treatment? Overnight monitoring. Recovery residency, they can come and go, but it's a safe place. It's a safe place for them to be during the day. There's some programming about how to reintegrate into life, how to reintegrate into society, to be able to be around other people with shared goals and create that onboarding. And that's different than residential treatment, which means you have a trained professional at 2 o'clock in the morning who will de-escalate you. That's the main difference. Now, at this point, and I've been all over the country, I have found a lot of people who call themselves a 3-1 who honestly are just recovery residencies. And then I've actually seen some recovery residencies who are easily 3-1s because there are people there that are trained and they intervene and they do these things. So the overlap for these is going to be an interesting change in density of this work, meaning how many of these are left when this one comes down and how do we certify it. Because with all of these levels of care, as we start to walk through a 0.7, a 0.5, and a 0.1 in these, there will be CARF certification capability with each of these. Meaning CARF will come and certify you for a level of care. Not whether you have a fire extinguisher and policies, procedures for safety, but do you meet the requirements for the ASAM level of care of 3.7, 2.7, and 1.7. Why does that matter? Well, it matters because the people who are able to get there are the ones that will get paid more to do this work. If you want parity, then we have to have parity with quality. And that quality can be definable based on a CARF certification level of care. And again, I don't work for CARF, I don't get any money from CARF, I don't get any of that. In fact, the 30 hours a week for ASAM Criteria editor-in-chief I put in is also gratis. This is important work that we have to, to get across the finish line so that we get it right. So what about this co-occurring enhanced piece? Well, when we look at this, you don't have to change your basic staff for any of the levels of care to be co-occurring enhanced. What you have to do is add access to psychiatry and then do a significant amount of training for those people that are in place. So we're not asking you to go hire a bunch of new people. You just need to make sure that the people that are there are trained to actually handle co-occurring enhanced care, which is different. It requires new knowledge and new capabilities. It requires maybe the addition of a quiet room as far as a physical plant is concerned. And then when we look at the referral capability, either immediate, depending on level of care. So if you're a residential COE, you'll need to have access to somebody immediately in that space. But for outpatient, you need to be able to get them really rapidly for that, either in-house or telemedicine. And then treatment, this means if you're co-occurring enhanced, that means if somebody has schizoaffective disorder, that you modify what you do for them. You don't just keep doing the same thing. You have to modify how you're going to approach that person with your care so that they can get the care that will onboard the behavior change that we want. So if we look at what that means when we talk about kind of screening, remember earlier when I said co-occurring capable is now gone? It doesn't mean we don't do it. It just means you're expected now to do it at every level of care. So that means you need to at least be able to do screening and referral for people. And that means as we go, so when we look at, you need to be able to do screening, you need to be able to do all of the evaluation pieces here and handle mild to low moderate issues with mental health, right? So that means if somebody has a major depressive disorder or they have well-controlled schizophrenia, you should just be able to handle that there. You don't have to be co-occurring enhanced just because somebody has schizophrenia if it's controlled. And I see a lot of people turning patients away for that reason because, well, I can't handle that. What do you mean? It's controlled. That's not the issue we're dealing with. This is the issue we're dealing with. So we're trying to set it up to where in order to be that CARF certification piece, you're doing deep screening as well as taking care of mild to low moderate people with a mental health disorder. because this is not uncommon. I mean, what percentage of patients, it's a little all over the place, but generally, what percentage of patients do we have a co-occurring illness who also have addiction? Yeah, it's anywhere, so 60% is a commonly used number. I would say that based on the data in the review, it's anywhere between 40 and 90. And it really depends on the population and location that you're at. So you have to judge for yourself what that is. But if you don't look for it, you're not going to find it. So ubiquitous screening for these is the minimum that we have to start with, and then being able to handle those people with mild to low moderate disease is important, and the ability to refer, not just like here's a referral, good luck, go do it, but actually coordinate that referral for evaluation for that. Things like assessment, like how are you going to document current care, documenting prior diagnoses, looking at all of the mental health systems and linking those symptoms to specific periods to understand, is this a primary mental illness or is this something that was caused by the substance? We have to deal with that all the time, especially with some of the stimulants. That becomes more complex for that. And chronic utilization of alcohol use disorder, it doesn't matter, because at the end, it's whether it was caused or it wasn't, the treatment is still going to be complex. And then utilizing, the preliminary diagnoses with DSM-5 or, not just like, do I think they quote meet for it, but actually using standardized clinical interview techniques to get at that diagnosis, which is why we need people who have psychotherapy capability, master's level professionals. For treatment, that means we need to be able to do stabilizing treatment, we need to be able to do maintained treatment, and so writing for SSRIs, SNRIs, things for those stable patients, we should be able to take some of those over if they can't find another provider outside of that, which means we have to train our providers better. We have to make sure that we all know how to do those things. Injectables there's no reason to not be able to give an injectable if that's being monitored by the appropriate medical professional for that. Now, there are billing issues of do we buy and bill, do we do this, and how do we do it? Those are administrative issues, not clinical. Specific psychotherapies, these are things that need to be onboarded for co-occurring enhanced. This is obviously not a complete list. I'm just making, showing some things that would need to be able to be there, which means you would need providers certified in CBT, DBT, EMDR. So right now is the best time to say that these things should happen, because we have billions of dollars in the system from opioid settlements that can be used for training. And it's wide open for that. And we've talked to a lot of the states around that so that these things can be pushed to the appropriate universities and or training groups so that these things can be done at scale for free for people delivering care inside of their state. Now, if we look at here with the co-occurring enhanced pieces, what does that input look like as compared to the other? The biggest one here is dense psychotherapy, but also an increase in medical. So we increase both the psychotherapy and the medical as compared to just a regular intensive outpatient or a high intensity outpatient. So what does this mean? So there's a lot of information, most of which you probably couldn't hear, but at the same time, the goal is to make you a little worried that you're not meeting these current criteria, that, wow, we should really be thinking about how we connect with this and how do we build this out and how do we shore up our policies and procedures and training. If you're fully comfortable with this, I want a breathalyzer done, because even I, in my role as a CMO of a place that I just started last week, am uncomfortable with this. This is hard work for anybody to have to put together, but this is what the data says. This is not what I say. It's not what one group said. This is 17 writing groups that worked independently as we pulled this together using the data, pulling in our psychiatric colleagues to help understand when a person needs to not be in the addiction system, but actually needs to go to the mental health system as their primary treatment modality. Integrating the utilization of other tools like the locus and connecting those in different pieces so that we know when people should jettison for a time being. There are times in which people just need medical care. Like, they don't need to talk about any of their stuff with healthcare. You have cancer that needs to be treated, a traumatic brain injury that's acute, things like that. We'll wait. We'll be here, but we'll get you later. So we need to make sure we know how to maneuver through those systems. And as we use that methodological approach, we realized that we had to realign the dimensions in order for us to get to an accurate level of care and build a treatment plan on top of that. Because if I say you're intoxicated, should I be doing a full assessment with you being mildly intoxicated? No. If you're in withdrawal, is that going to be really helpful? Are you going to get really truthful? How many times on the very first interview with your patient did you get a whole bunch of truthiness? I don't know, maybe you can get that, but we generally have to make some changes to our assessment over time as they trust us, as they connect with us, and as we create a therapeutic alliance with them. So one of the other things with this realignment of the dimensions is that we're breaking out the initial assessment. We're going to have a 26 to 27 question level of care assessment. Once that's done, they go to the level of care they should be at. Then they get the deeper assessment. So people who have made a living off of billing for a full assessment on day one, you need to modify that because that's not going to be how we state that the data shows it should be done, which means an ER should be doing the basic thing so they know where they should bounce. If you have a central community asset like a community mental health service that spends 2.5, 3 hours with a patient, tells them what level they need to go to, and it says they'll be ready for you in 2 weeks, that's a wasted time. That's just wasted time. And so it does nobody any good because when they go to that place, do we just take that assessment and be like, oh, this is great. This is exactly what I would have gotten. No, we trash and then we start over. So the patient has to do it all over again. So this doesn't make any sense for a system that is already, constrained by lack of people to work in it, constrained by, a number of people on waiting lists and need time and energy and capability to get there. So as we look at this, we need to make sure the dimensions as drivers of care is what we focus on. So if you're at a 0.7, what dimensions would be driving your need for care at that point? 1 and 2 could be a little bit of 3, right? You could have acute psychosis, you could have acute suicidal ideation, which sometimes would be medical, sometimes not. But with that, so that's 1. So if I'm at 3.5, what dimensions are going to drive my care? Yeah, 3 and 4, the new 3 and 4. Everybody will be saying the new or the old for a while, but then we'll just be into the new and it'll just be is what it is. We promise not to change it for another 20 years, at least while I'm alive and doing this. We're not changing. So what about a 3.1? It's kind of like a 3.5 except less required, meaning if you have a severe issues with 4 and 5, then you would go to a 3.5. If you have mild to low moderate, then you would go to a 3.1 or a 2.1 depending on your dimension 5. And so thinking about this is helpful because how many people have had to have a large-scale argument with utilization management? Because they didn't like your note or because they didn't think you talked about what it was. If we know what the dimensional driver is for a level of care, what got them there, then we also know what we need to fix. And once we have stabilized it, then they should be triggered to another level of care, which is why we wanted to align the system so that if you're a 3.5, you can automatically be a 3.1. Because that way, if they don't meet for 3.5 for 2 days, you're not just going to eat that cost. They're just now a 3.1. Magic. Patient doesn't have any idea, right? It's just same bed, same people. They don't have to go to a new place. They don't have to do these things. It allows them to stay in a single location. And if you're a 3.7, that means when you wake up and you're a 3.5, it doesn't matter to you. You still go get lunch at the same place. You just see the therapist rather than the nurse. We need to build that cohesive system just like we would in a normal healthcare system where if somebody's in the ICU, now they're in the step-down unit, now they're in med-surg, now they go to outpatient rehabilitation after their hip replacement, and then they move on. And that's kind of what we need to create here is that system of care that is connected all the way through. And the cohesion of the tense place was something I really wanted to focus on with that, so the 0.7, 0.5, 0.1, because I think if you can get that structure and recognize the dimensional drivers, then it makes it easy to understand what staff you would need, like there's no question. And then when somebody says, I'm a 2.7, we'll automatically know what that means. We'll just know. Instead of right now, if somebody says I'm a 3.7, I don't know what that means. Which, are you 3.7 withdrawal management or 3.7? Or based on the book, does it really matter and does it specify? No, to be honest, if you were to look in the 3rd edition, you could kind of be both or neither at the same time. Less interpretation here, but enough for it to be locally interpreted based on culture and capability. So like if I'm building this system for a tribal community, the system could still look the same, 0.7s, 0.5s, 0.1s, but what occurs within those systems could be very culturally different. And so that's perfectly fine, because all we're really saying is, do you need medical, do you need therapy, or do you need education, and how much of it do you need? I'm not telling you what you need to do. And so culturally, what we want to be able to do is have that drop in, have the structure be familiar no matter where it is, but with the cultural changes needed for that population that it's being directed toward. And that there's a clear continuum that we can explain to families. I've spent a lot of time trying to explain this. I've recently had to explain it to my own family. I've had a brother-in-law who's required care, multimodal care that didn't exist. And so that was a lot of phone calls and a lot of explanations about what the care system should be, but it's not. A couple of raised voice moments in that setting with a sheriff and a defense attorney, but other than that, I think at the end, we're gonna be able to offer a clear continuum of care that people can feel comfortable. Just like if a family feels comfortable that my loved one went to a hospital, they're somewhere safe. I just want them to feel like they're somewhere safe, even if that safe is outpatient, because right now they don't feel safe unless they're kind of locked up. But now with the added piece of the recovery residency, we can have them in a place that's safe from a housing standpoint, getting that addiction treatment milieu while they're getting outpatient treatment. And this should allow for that, to happen without the 7-week wait for a 3.5 or a 3.7. All right. So I think we've cleared out to the people who actually need to know the criteria. And so this is a perfect size for me to actually answer questions as compared to the others. So we have a little bit of time for questions. I think you guys have a 30-minute break, and so I'm happy to take those. Otherwise, thanks for having me and dealing with a reverby, room. I think either way it would have been hard to hear, because now that there's not as many people, I hear myself and it's annoying. So it's tough. All right, thank you guys.